Okay, so this is like a typical, this is kind of a, we would call it a factoid question. You know, it's basic fact. You know what you're talking about? Okay, and everybody should know the answer to that, right? It's all preganglionic fibers of the autonomic system use the neurotransmitter acetylcholine. Okay, those are preganglionic, postganglionic, and autonomic systems are different, right? Right? The parasympathetic and sympathetic, right? Everybody remember all that? You better. This is another kind of, this is just a simple factoid. These are sample questions that they have in their little brochure to show you. Do you know what the typical pass rate is per administration? No, I do not, but I can show you some information when we finish this section. Okay, monoamine oxidase inhibitors produce effects by inhibiting the reuptake of norepinephrine, inhibiting the degradation of norepinephrine, inhibiting the reuptake of acetylcholine, decreasing the amount of norepinephrine available at the synapse. So now see this, all three of these, they're lined up, and they've got nice stems, they're almost equal length, and then you have this down here. So some people would be fooled and want to pick that. I don't know why. Okay, because the answer's up here, number A. Okay? Everybody sees that? Good. We're all in agreement, right? Okay. This is a no-duh for me, because if you hear grapefruit, you probably heard about grapefruit being bad to take when you're taking a substance because of the interaction, right? Everybody's heard that, right? Raise your hand if you haven't. Okay. Yes. Okay. Thank you, Peter. So whenever they say grapefruit, you're going to want to check grapefruit, okay, because that's clearly a potential problem. Now the problem isn't as they depict it, because it depends on when you drink the grapefruit juice. Remember, people don't just continuously drink grapefruit juice while they're taking medication. It would be when they take their medication, they might use that to swallow that medication. So that would be a problematic. But if the person had drank some grapefruit juice, say an hour ago, would you say that they could take their drug or not? Yeah, they could take it. Rachel says no. No, you probably could take it. Or how long would you want the reverse? How long, if the person had some grapefruit juice earlier that day, let's say it was 30 minutes before you took your medication, would that be okay? Meaning, possibly. They're not going to ask that detail of a question, okay? That's not going to happen to you. That's another thing. They don't hit you a lot with the dosages of drugs, okay? They do more of these kind of conceptual things. Is this going to be a problem? Okay. Yeah, time in the stomach, but remember it's going to go into the duodenum pretty quickly because it's a liquid. It'll pass through. Let's see another item. But it's something you want to think about. And that's the beauty of doing a lot of questions, because now you're going to start to try to reason, and as you go through these questions, things are going to be retained because there's only so much you can ask. I thought MAO inhibitors were involved with enzyme degradation. Okay, let me go back. Now you got me confused. I mean, in a way you're right, but it's not this. I still think this is correct, but I'm going to have to go back and look at it now. I'll check that out for you when we take a little break. Here's a 7-8. Now this is more like the kind of question that you're going to see, okay, that you'll puzzle with. A 70-year-old female patient reports feelings of tension and excessive worry. She has a history of osteoporosis. Okay, that may be important, may not be. Reduced renal clearance may be important, may not be. Mild COPD may be important, may not be, and hypertension. Hepatic function is otherwise normal. Which of the following medications would be most appropriate? Now, they're not asking you whether you think it's a good idea to take a benzodiazepine. They're asking you which one if you had to choose among these. Yeah, you may be right on B on that. We'll go back to that in a few minutes. Okay? So, temazepam? Christine, is that what you said? And Peter, you're picking B? Librium? No. Okay. You're talking about the other question. Right. Okay. Okay, you're going along with the lot thing. Everybody remembers what lot is? Lorazepam, oxazepam, and temazepam. And they are what? They don't, what's unique about lot? Essentially, yes, it's liver friendly to, they're benzodiazepine, it's liver friendly, right? So you don't require that type of great metabolism, right? But what are the risk factors for this patient? What is the risk factor for any kind of a benzodiazepine for a 71-year-old female? What's the risk factor? Falls. Okay. So what determines which drug, if you say, okay, falls might be the greatest risk with this person, okay, what would determine your choice? The shorter acting, right? That's right. Pep 8, shorter acting, better, right? Yep. Okay, so which one is the shortest acting? Right, D, absolutely. But that wouldn't be something you would be thinking about, right? Most people get, I'm not going to give alprazolam, because you hear all this addiction stuff. Well, that's not a big issue typically with a 71-year-old unless you're giving them too much anyway. But the idea is that this stuff accumulates in the body, especially as you get older and you have more fat, right? With that accumulation, there becomes an increasing risk of fall. Since, if you look at this one, it has to be metabolized by the liver, but the liver is fine. There's no big issue there, right? This one doesn't, okay? But we don't care because the person has normal hepatic function anyway. What does hypertension have to do with this? Nothing, okay? Little reduced renal clearance, most elderly people have that. That's not a big deal. Mild COPD, chronic obstructive pulmonary disease, that's not a big deal. Usually, unless you're going to give them large doses, which could decrease their breathing, which would more likely happen with long-acting drugs that were given over a long period of time. Okay, I think I got this. Let me look at something in a minute. A 45-year-old female on an inpatient unit who has been recently treated with haloperidol develops hyperthermia, rapid heart rate, pallor, and muscular rigidity. These symptoms most likely indicate the onset of spinal meningitis, neuroleptic malignant syndrome, and agranulocytosis, a condition unrelated to the medication. Everybody picks up on that. Nobody's having any trouble with that, right? The double-blind, placebo-controlled design psychopharmacology research has been criticized because reports of side effects may clue clinicians into the experimental status of the patient. Placebos are too variable in the effects they produce. Clinicians may subtly convey to their patients their expectations for improvement depending on whether the patient is receiving the experimental drug or the placebo. Patients become aware of their experimental status because placebos have no side effects. Well, we know that last one's crazy. What do we got? We got some B's. We got some D's. We got a couple of A's. Okay, we got A's, we got C's, we got B's, and we got D's. Okay. All right, so why is D not correct? Why would you say D can't possibly be correct? Come on, take a chance. Put it out there. Everything has side effects. Thank you, number 6. That's crazy to say placebos have no side effects. Of course they do. That's what the comparison is. So when you have package inserts and you're kind of giving a patient a medication and you have a package insert, you know the PDR is nothing but the package inserts. I hope you all know that by now. But in any event, the package insert for the drug will have the placebo study stuff in there with them. And I use that as a time to educate a patient about placebos because I'll say, okay, here's how we know which side effects we need to pay attention to. We have people taking the medication and people taking the sugar pill that has no active ingredient in it, and we call that a placebo. And you'll see, if we look at the line that says headaches, 10% of the people on the medication complained of a headache, and 6% complained of a headache on the placebo. The thing about side effects is any time during the study they complain of a symptom. Because they use that as the standard, it becomes very difficult to see which ones come on early, which ones come on late, which ones seem to fade away quickly, and which ones don't. So we're kind of missing that information. We don't get it. What we get is if this was reported across the study. So the answer is supposed to be that. That's what they said in their little chart. Okay, everybody in agreement with that? A or B? It's A. That's what they're saying is the answer, the best answer. Okay. All right, this is the chart I was mentioning. Yeah, it's a little hard to see, but these are the number of test takers, 74. This was accumulated from 2000 to 2007, so it's probably fairly accurate. Okay, and so we had the number of tests here, the mean total score here, the standard deviation. What is this next one? It's hard to see. Oh, this is the first category. The second, this is neuroscience. This is integrating psychopharmacology in the practice of psychology. This is nervous system pathology here. This is physiology, pathophysiology. I'm sorry, I didn't put my arrow down. This is biopsychosocial and pharmacological assessment, monitoring. This is differential diagnosis, pharmacology, clinical psychopharmacology, research, and then professional, legal, and ethical interpretive factors, I guess. I can't read that. Interpretive? Something or other. Issues, rather. Okay. So if we say the pass rate is 50, anybody got a calculator? Pass rate is 51%. What would that be? What would the cutoff be? Anybody got the figure? So it'd be 106. Okay. So if you're 10, so if you look here, the average is pretty high for Reliant for the total score, and that's all that really matters. You can go through these categories and say, well, who's doing the best in neuroscience? You know, if you want to, which is what I teach. And so they do pretty well. That's all that matters is the final score, though. If you look at Farley-Dickinson, they have a little lower level on average. Okay, it's just under the cutoff. If you look at Illinois School of Professions, there's only 5 there, though. So these are more. There's 74 here and 49. Okay, so you can see they don't give you the final number that passed. They just give you the mean score. So you could draw some inferences from that. It may not be completely accurate, but in general, this is what it looks like. When you have a small number of people, obviously, if somebody does terribly, right, it's going to skew it in a bad direction because we're talking about means here. Okay, and so you go on down the line, you can see. So far, Alliant can hold its own. But then Alliance, one of the universities that are people are taking this test more often with. And Farley Dickinson, obviously they're doing fine too. They're just a little bit below the cutoff, so that could just be one person's bad performance. I don't know why they decided to do that, to make that part of the graduation. And the reason I say that is if you don't have any likelihood of getting a bill passed in your state, taking the PEP might be something you can hang on the wall, but it's not going to have any big meaning for you. I guess it's one way of saying you know something about psychopharmacology that maybe some other people don't know. But as far as a test goes, if your state develops a law, the one problem you might be facing is if you took this 10 years ago and they develop a law that's going to say something along the lines of the test has to have been taken in the last 3 years just to demonstrate that you're current. Because you could take these tests 5 years ago and never looked at anything associated with psychopharmacology again. We don't know if you kept current. Now, you might be able to try to say that CEs are possibly an indication of that. I guess if you could demonstrate that you were taking a lot of psychopharmacology CEs, yeah, I suppose that might pull it, but you'd have to write that in the bill. That's where the problem's going to come up. So New Jersey has a bill in assembly at the moment. Do you know what it's saying about the PEP or anything? Any test? Can you call yourself a medical psychologist if you pass the PEP? You could call yourself a medical psychologist if you want to. It's not necessary that you pass the PEP. It doesn't give you a title. It does raise the percentage of graduates who pass. It does raise the percentage of your graduates who pass the PEP. That's true. It does do that. The WISE bill's got moved off another year. I'm not surprised. Gail, what's that mean? I think the school required the master's students in FDU to have some sort of capstone exam. Yeah, that's what APA is trying to do, to get to demonstrate skills. They recently changed it to a different exam. That's interesting, because I remember the discussion about the capstones. Iowa has a study bill in both chambers, that's right, and it's in the Legislature Bureau for writing right now, so you don't know exactly what their status is in terms of the PEP, right? Okay. So everybody here waited till we had a bill. Yeah, we can have a quick break. We're at the end of this, okay? So, all right, we'll stop at this section. I'm sorry, I get going. Thanks for reminding me. Let's take a little break. Okay, Medicaid expansion should increase number of bills. Maybe. But I tell you, just so you know, it's a tough political fight. It is a tough political fight. How long a break? Let's take about 10 minutes, 15 minutes, somewhere in there. 10 max, 15 if you want 15, that's fine. Okay? Because we're not having a long session. We stop at 8 o'clock, I guess, my time, which is, I guess, 53 minutes from now. Okay?
John?
Yeah. Wendy.
Wendy, yeah. I used to be the associate director at the SPPAIU in the psychopharm program.
Oh, that's great.
Yeah, so that's me. I'm just trying to update myself here.
Okay, well, good.
Good to see you.
Yeah, good to hear from you. I heard from you in a long time.
Yeah.
Yeah.
All right.
All right, we'll talk later. Okay?
Hey,
bye-bye.
John?
Bye-bye. Yeah.
You have a minute?
Yeah, sure.
I was kind of going with that idea of trying to pick a couple of books or 3 or whatever that I could really just bone up on. And actually, and I know everybody probably has a different perspective, but I had been told the Muse book and the modeling book of psychiatry. Familiar with that one?
Not off the top of my head, but I've tried to review as many as I could. Like I said, the Muse book is edited chapters. It's kind of light in some areas.
I feel like it's not enough, huh?
No. I would play with his questions, and you're going to have those anyway if you want them, because I got them all together pretty much. And in fact, that's going to be in your package of things that you download. The two books that I'm talking about, the psychiatry one and the principles of practice of psychopharmacology, honestly, it'll get you where you need to be. Okay? I really believe that.
Yeah. I appreciate that. That's good. Good word.
But I'm also there may be a few things in there that you don't get, and that's why I put that cheat sheet together just to make sure you're getting those fundamental things. Like you need to know what the drugs are actually approved for. Okay? Because that comes up as a question every once in a while. And they put you in a bind where you have equally good medications, but one hasn't been approved, and you have to know the difference. They do that kind of stuff.
Which one's on label and which
Yeah. Hello? Here? Everybody here? So, can I get back on this? I went back and I thought about this one, looked at something, and it's absolutely right, B. I don't know why I thought that. Strange. I hadn't looked at the question in a while, I guess. All right, so well, if you're going to take the PEP right away, here's my best advice for you, is essentially get your 90-day window. It's going to take you a month to even get a date, so get that done. Take your 90 days, and just study like hell. Okay? That's what I would do. I think that'll work. And then when you feel like you can answer more questions than you want to, then you just hold your breath and close your nose and go do it. All right, so I think we're done with this section. Any other questions? So that was right. B was right. I don't know what the hell I was thinking. It's obvious now. Not just norepinephrine, right? All of the monoamines. Right? It's all of monoamines. Take-home point for the weekend, study like hell. Yes. But honestly, as I've said, those two books, the first two, with maybe a little bit of looking at some of the Muse chapters, which I'll probably try to select out that I think are good, I think that you can pass that test. Take-home point for the weekend. What is the next step for licensure in Louisiana after the PEP? You mean, what do you have to do to get your license after you pass the PEP? Well, there's a process. Well, first of all, you have to be a psychologist, licensed psychologist. It doesn't necessarily have to be Louisiana. If you're licensed in another state, you could do this. Okay, and then you take the PEP and you file your application with the medical board, and then the medical board reviews it, has it passed by the group of psychologists. There's 4 of us that sit on this committee, and we review the credentials, we review the information that's put forward, and they have to, then you apply, you'll get a number, and then you can apply for your substance abuse, there's licensors, controlled and dangerous substances, and the DEA license, and then you can start prescribing. But for 3 years, you're under some degree of monitoring, meaning that you have to always work with the family practice doc or the referring physician in terms of how you order prescriptions. But you're able to prescribe right after that. There's just some certain things you have to do to be able to do it properly. I tried to look up MAOI in the Muse book. I was not satisfied with it, but I read it, money not well spent, right? It's not that good of a book. There are a couple chapters that I would point out, but that's about it. Let's see. So the answer is B, because you're inhibiting the degradation. That's what the monoamine oxidase inhibitor is. Monoamine oxidase is being stopped, right? So you're not going to degrade the norepinephrine. All right, good to know. Okay. Anything else? Is Muse Pep quiz good? I think some of his questions are, and you're going to see a lot of those today on Sunday. That's kind of, we're going to do some things, and I have some other things that if we get through them that I want you to look at. But a lot of what I want you to look at really comes from the psychiatry book that I mentioned in the beginning. It's really very concise. I'm telling you. If I had these two books when I took the PEP, I would have been delighted. Because it's very succinct. It gives you the information you need to know without a lot of fluff. Okay? So, what is this? What about these three, Christine? Oh, can you go over a lot? Oh, yeah. These are the drugs. These are the benzodiazepines that don't require hepatic metabolism. So in other words, the CYP enzymes are not an issue. Lorazepam is frequently used for sedation, for rapid sedation. Temazepam is Restoril. It's an old sleeper. Oxapan, I forgot what this is. I think it's Cerax. I don't use that. I do use lorazepam frequently. Used to use temazepam, but I tend to go with the newer things. I like Lunesta right now as a sleeper if I have to. And Silenor. Anybody familiar with Silenor? When it works, it's great. Anybody? It's a new drug out. It's not a new drug, by the way. Cinequan, no. This is Silenor. It's a sleeper. And the way it works is it's actually a histamine blocker, histamine 1 blocker. Kind of like what you get in Benadryl without all the fuss. And what happens, what it actually happens to be is doxepin. Anybody remember doxepin? It's one of those old tricyclics. Right, okay. And what they did was they tweaked it down to a very small milligram, so it only acted as an H1 blocker. H1 in the brain wakes us up, so a blocker helps us sleep. Remeron's different. Remeron makes you eat a lot, so you have to watch that, which is good when you have somebody who's anorexic, but not good when you have somebody who has problems with their weight. Yeah, it's doxepin, and it comes in a 3 and a 6 milligram. That's Silenor, and you give it on an empty stomach. Should be on an empty stomach about a half an. I think it's 2. They want you to be empty, your stomach to be empty for 2.5 hours, I believe, which might be a little difficult for some people. But when it works real well. But here's the problem: the cost for 6 milligram is $200 a month. Now, since I'm aware that money doesn't grow on trees, just like you guys know. And so I tend to want to look for other more effective ways of getting people medication without spending an arm and a leg. For some people, $200 a month is ridiculous. So I'll take their samples, but I'll never order that particular drug. And so I figured out I could find a liquid version of doxepin that was essentially, what was the ratio? It was what, 1 milliliter per milligram. And so, and you can get a little pipette with it, and you can basically pull up 6 milligrams, and they can put that in a little apple juice, swallow it down with an essentially empty stomach, and it'll work for them. And that only costs $15 for 3.5 months, as opposed to $200 times 3.5 would be $700 for that period of time. It's a huge difference. It's a huge difference. So it's an old medicine that gets retooled. And that's true with all of the stimulants. I mean, the stimulants, we really only use 2 major stimulants, and